think we'll go ahead and get started in the interest of time so that we can maximize the time we have for discussion. I know that there's still people trickling in, so just grab your lunch and come down to the front. And so I just want to welcome you to what is the fourth in our five-part Journeys in Medicine series. And this is a very special session because as the last session, we had a lot of our community members talking to us about the issues in the community and ways in which Hopkins might be able to help. And that was a very powerfully informative session. And for some of you that were present at the end of the last session, one of our internal medicine health staff asked, well, how do these social issues and other issues relate to how we interact with our patients in the hospital? So that was actually a perfect segue into what we're talking about today. So this session is called Journeys in Healthcare, a conversation about the healthcare system in the community. So in other words, how do we as Johns Hopkins, as a healthcare system, as providers and caregivers within a system, how do we relate to our patients? And then how does our health system itself and our organization relate to the surrounding community? And so the organizer of this session and our moderator today is Dr. Lisa Cooper, who is not a stranger to any of us in the Department of Medicine. She is professor of medicine, epidemiology, and health policy and management here at Johns Hopkins. She also is a core member in the Welch Center for Prevention, Epidemiology, and Research, and is also the director of the Johns Hopkins Center to Eliminate Cardiovascular Disease Health Disparities. And Lisa's just had a very creative and innovative way of really highlighting the important role of a patient-physician communication and how that really impacts care delivery for our patients. And for that work has been received the Genius Award from the MacArthur Foundation and is also a member of the Institute of Medicine. So I'm going to let Dr. Cooper take it from here. And again, just like the previous sessions, we will invite you to be interactive. And Tamela Knox now will be walking through with a mic throughout the session. So. Thank you, Dr. Golden, for that wonderful and warm introduction. And Dr. Anderson, and thank you all for being here to have this conversation with us about the healthcare system and the community, and importantly about relationships and communication and what role they play in helping to address some of the social inequities that have led to a lot of the problems that we've seen here in Baltimore and across the country and actually beyond. So today we have a very committed and passionate group of individuals who are going to be participating in the conversation. And before we introduce ourselves, I'd like to just give you a brief outline of what we plan to do today. So first, we'll start with very brief introductions, and I do mean brief. 30-second introductions of each person who's agreed to be on in this conversation. And I want to thank each of you also for taking your time and for being so caring and committed to this issue. So we're going to start with the brief introductions, and then we will start the conversation. And the conversation will go on probably for about an hour. It might be less if we are not so talkative and passionate today. You are welcome if there's something that particularly grabs you and you really want to jump into the conversation to do that. However, we do plan to have quite a bit of time at the end to engage with you. So if it's not a really, really burning issue, if you can just sort of listen in to the conversation and then join in with us when we break, that would be wonderful. In the meantime, we're also going to have some slides that will be showing in the background. The slides will have information that comes from studies that I've done, studies that have been done by several colleagues. They're going to have quotes from patients, from health professionals, from students, from community members, just about different issues related to communication and relationships. And then there will be information related to health and healthcare disparities. We don't mean for those things to be a distraction to you. You can look at them at your leisure. If you are engrossed in the conversation, you don't have to look at them. If you want them later, they will be available. The slides will be available. Also, any articles or references that you might be interested in, we will make sure will be posted on the blog for the Department of Medicine. So thanks again for being here, and we're going to start our conversation.
My name is Michelle Simmons. Good afternoon. I'm a patient, representative, and a board member.
Good afternoon. My name is Carlton Hayward Jr. I'm an assistant professor in hematology here at Hopkins, and I'm also a member of the community of people living with sickle cell disease.
Good afternoon. I'm Reverend Deborah Hickman. I'm founder and CEO of Sisters Together and Reaching, and I am the community co-chair for Cardiovascular Health Disparities Group.
You already heard it, why now?
Good afternoon, I'm Mike Albert. I'm a primary care internal medicine physician at East Baltimore Medical Center, and I'm also the regional medical director for the Baltimore and North practices of Johns Hopkins Community University, so Baltimore all the way up to Carroll County and Parkland County.
I'm Kim Gajuni. I'm an assistant professor of medicine in the Division of General Internal Medicine, doing research out in the community in Baltimore.
And I'm Brian Taltone. I'm a Baltimore City Public Schools administrator. Currently just been temporarily reassigned to labor relations, so it's funny because they put the time stamp on here in reference to the quick introductions because of me. I was the one who was doing all the talking probably last time, so that's the quick part of it. So.
Well, I guess I don't have anything to add to that. I think we all tend to get pretty passionate about this topic, and so we all go on for a while. So we just want to make sure that everyone has a chance to share his or her perspective, and that you also have a chance to engage with us. So I think where I'd like to start is talking with Kim, Dr. Kim Gajuni. So Kim, I understand that I know from working with you over the years, you've been a researcher here in Baltimore and have done a lot of work with community members. So I'm just wondering if you could take a few moments to talk with us about what you've learned, what some of your experiences have been in working with community members, and just anything you think other researchers might want to know, people from the community might want to know about working with researchers. What have you learned that we can all sort of benefit from?
Sure. So I guess I'll start by saying the whole reason why I got into medicine to begin with was actually to work with the community and to work with vulnerable populations. And so over the last few years, my trajectory of my research career really has been a direction back into getting out into the communities and understanding what their needs are and where is there a good synergy where we can work together. So I started this process. So most of my community work now is actually in the public housing developments in Baltimore City, and for those of you who don't know, public housing is a very low-income population with a significant burden of health disparities. There are pros and cons with working in public housing, but ultimately it has been a really great experience for me, and I hope also a great experience for the communities that I work with. When I first approached them to talk about if this is something that they might want to engage in, I initially was met with a lot of skepticism. So I heard lots of stories about their past experiences with researchers coming into the communities, collecting their data, and then basically leaving. They never heard the outcome. Well, what happened? What did you find? And there weren't really any actionable changes that occurred after spending and giving their time to participate. A lot of times they perceived that a researcher would come in whose focus was clearly on one topic that may be important, but it wasn't important to the community. And so there was sort of a disconnect and not an alignment of priorities. Despite these kind of negative feelings, the communities and individuals that I spoke with actually saw the scientific community and actually Hopkins in particular as a potential for really great collaboration. I think that they see the value of the resources and they see the potential of what we could be. But to date, most of them actually hadn't experienced a true partnership. So what I'm currently working on, as I mentioned, is out in public housing. My overall area of interest is obesity, thinking about healthy diet, exercise, other lifestyle behaviors. And so in working with these communities, I didn't want to sort of recreate the same cycle that had occurred before. So I like to think of how researchers can engage with communities, that it's really the relationship that we build, I think, has to be really important. And not just, this is a relationship for this one study, but that I'm actually interested in working long-term over the course of my career with these communities. And so I've done a number of things to try to build that relationship and make this more of a partnership rather than this is just a population that I work in. So a few of the lessons as far as thinking about building these relationships with communities, a couple of things that I've done that I think have been successful. So I think the first one is being a good partner, and what does that mean? I think there are simple things, first of which is just continuing to show up to meetings, and that the community has realized that, you know, it's been now 5 years that I've been working in one community, and, you know, I know most of the residents there and the staff, and really it has become more of a partnership, not just me coming in with my ideas, but what does the community need? In that same vein, I think it also takes listening to them and not always doing everything that's directly related to our research. So the community has its own priorities. I participate in things like health fairs and youth day events, which have no direct implications to my research at all, but because I am a partner with the community, these are things that we do together, and we actually plan them cooperatively. I think it's also important to actually share preliminary results with the community. So they actually are extremely curious and want to know. They have invested their time and they just don't want it to go out the window. And so in all of my preliminary work, I actually go back into the communities at their meetings and I share the results that we found. And I actually get not only incredibly insightful feedback on what I'm presenting, but they come up with next steps and where we need to go, which has been an amazing collaborative experience. I think it's also critically important for you to really understand the communities in where you work. So this can be done in a multitude of ways. The approach that I took was, before starting this project, I actually sat down with leaders in the community, within public housing, to get a sense of what are the priorities for these communities, and then did a series of focus groups to understand, well, is healthy diet and exercise something that the community actually wants to focus on, that they feel they can focus on? So we had alignment. Obviously, there are other priorities that I'm not currently addressing, but I think that there are other potential people at Hopkins out there who have these interests that the community would be really interested in working on. I think the final thing that I'll say is that I think we need to not only build relationships with the individual community members, but thinking about within organizations that can potentially disseminate our findings. So if we develop an effective program and we have the research money to do it, that's all well and good, but if it doesn't get disseminated more broadly, then really all of this work has been for naught. And so I think you have to have a little foresight to do that. So I've actually, again, established a relationship not only with the residents of the communities where I work, but with the Housing Authority of Baltimore City, so that if the program that I'm working on is successful, you know, we're ready to disseminate that to other public housing communities in the city. Obviously, there's challenges with that, but I think having that foresight is really, really important, so it's not just this one and done. I guess we'll switch over to Debbie now. And so you are on the other side of the equation as a community partner. And I guess I'm curious to know what has your research or your experience been working with Hopkins researchers and clinicians, and what do you think that researchers should know about building relationships with community members and organizations?
So I've had quite an experience of working in research over the last 31 years, especially starting at University of Maryland and working for the Center for Vaccine Development is where I really initially got my start, and then moved into HIV and AIDS research. And so I would say that lessons learned and things that, you know, working with researchers here as well, is that the first order of business in the formulation of the research concept is where the community really should be engaged. They should be at the table at the time that you wake up from having a dream and saying that I need this person and I need these resources to be identified in order to really begin to put it together so that when it comes down to recruitment and marketing of the research to get the participants in, that the community is already engaged in the process, that their voice is already at the table. I think that that's a critical missed opportunity, and it also prolongs and causes us to have to go back and forth and readjusting our research aims, because if we don't start that process at the concept stage, then we are always trying to modify it in the implementation stage. And so those are the things that I really think very strongly about. And I also think at the concept that we need to begin thinking about sustainability. How do we sustain? Because the community hears it as that you are coming in and you're offering them this option over here and this option over there, but they don't see it that it's just research. They think that you're actually their provider. So they look at you as the nurse and or the doctor that's going to be there forever. However, if the study is only 3 years or 5 years, and when it comes to a sudden end, it leaves a sudden death impact in community. So thereby the next researcher that comes along will not have such a success in the recruitment phase because the community is becoming hesitant and suspicious and feeling like, okay, we did this and we did this and it had great results in our community, and all of a sudden it left us and without any resources to continue the process. And so I think it's always important that we do those two things specifically: engage community at the concept and make certain that sustainability is ongoing, and that they are always a part of the ongoing updates of what is taking place and why is there necessity to actually modify, to respect the community and not do things to, but do things with, even in the conceptual stage of making certain that we are looking at, we might want to do the diabetes study and say that we're going to be able to prove that if you limit the fat intake or if you increase your exercise, you'll be able to avoid diabetes, but they don't have that clear understanding that there's also some genetic factors that might be mixed in there. And so if we don't really do a thorough education before we even begin the implementation phase, then we have done a disservice, because the information that the community gets, it's its own marketing entity. And it goes about from door to door and says this and this and this, and it forms negative opinions, and so the institution gets hurt by it. And so one of the things that I would really, warn us about is making certain that there are community faces as well as voices that are always out there in the forefront, along with the providers that are actually providing research. Those are critical factors that I would say. And then looking at that, I would say, Mike.
And I wanted to jump in before we move on to Mike, just to ask you to just elaborate a little bit more on how you think the researchers can do some of this. Because I think a lot of people know in some way that they're supposed to do this, but they're not really sure. Like Kim talked about it a little bit more, but from your perspective, what does it look like when a researcher is actually doing that?
What it looks like when the researcher actually is at the stage of actually engaging community is the researcher coming, identifying him or herself and what they would like to do and asking the question of us, the community members, are you the leader or are there other leaders that I need to be engaging in this process? You can come to Deborah Hickman for a lot of things, but Deborah Hickman will pass the baton to someone else, because Deborah Hickman is not the be-all, end-all, and nor should community members engage in a space where they think that they know this or that, but we should, know what lane we're in, and we should move in that lane, do an introduction of the person. I want to introduce you, Kim, to Dr. Cooper, because she's been working with these groups in community, and she knows Leon Purnell, and Leon Purnell knows Willie Flowers, and Willie Flowers knows Bernice Tucker, and all of these wonderful organizations that actually will be able to assist you in navigating and reaching the community. But you need to start now. You need to bring them to the table now and make certain that they have the education, that they have the understanding, and that you're doing your marketing piece accordingly, because I think that that's another missed opportunity. We do, when I say we, I'm talking about the institution usually does marketing from its very conservative perspective. But when you're asking us, the community, to go out and put this into the community and be a part of the recruitment, it has to look culturally appropriate. It has to ring those bells that say, wow, I want to read this, I want to understand this better, and I know how to promote it in my community. And yeah, my auntie would like to be, is interested in it. You even have to do it for the church. You have to fix that bulletin just right to go into the church bulletin, so that the mother of the church says, we need to get these people in here so that they can educate us about what it is that they're doing. Yeah, and so I think along those lines, you know, Dr. Albert, Mike, I love you. I love your personality. I love the freshness that you bring to the East Baltimore Medical Center, where you've done a lot of work with community members. And in so doing, I really would like to know, what are the issues that you deal with on a day-to-day basis that help you to help the people in community? How is it, what is it that you need for the community members to know about what they need to come prepared to deal with when they come to East Baltimore Medical Center? What do you need for them to have when they come in, so that you can best provide the appropriate care and services for them to keep them coming back over and over again and being compliant to their medication and to all of the other structures that you would like them to put in place when they leave your office?
Thanks, that was a very nice introduction. Something to follow up on that. So as a practicing clinician in the community and looking at the whole of primary care in our organization, part of me wants the community to know, and then part of me wants the community not to know what's really the challenges facing medicine, but particularly primary care medicine. Primary care medicine's evolved in a lot of ways, not all of them good. It's relied on extraordinary providers and teams to take care of patients and do extraordinary things every day to manage patients. And if you expect the system to sustain itself with extraordinary efforts on a day-to-day basis, that can present challenges. And so, as it's not a secret to anybody, primary care physicians and providers and teams are now faced with increasing volume of patients. There's a shortage of primary care physicians. There's a huge burnout rate in primary care, largely due to the increased number of tasks that are now asked of physicians. And so in all of this, physicians love doing what they do in primary care, and that's why we're all there. And we love our bond with patients and with the community. And so that's why we want to shield patients in some ways from the realities of what's behind the curtain, so to speak, because that's the sanctuary, the exam room, the time with the patient. What we'd like community members not to know is how many buttons we now have to click to prove that we're delivering quality care. And we recognize that's important so we can get paid for quality and not for quantity. We know quantity can be the enemy of quality. Those are challenges as well. We really, we have to navigate a whole system that's sort of stacked against us now. We'd like community members and we'd like patients to know that the success in the future is going to be us learning to work in teams, and patients also learning to be cared for by a team, because the primary care physician, as the traditional centerpiece of primary care, is a good concept. I think the physician is a centerpiece of many parts of the care around medical diagnosis and treatment, but there's so much more patients come asking of us, and rightfully so. We should be able to deliver it. And so that's the challenge that primary care physicians feel. I think they want to, and they feel they should be able to deliver everything, but the system is stacked against them and everybody. So, we can, whether you're talking about housing or schools or parenting or medicine, there's so many teams that can come together to help patients. But in the realm of medicine itself, physicians simply can't be a diagnostician, the educator, the community health coordinator, the social worker. So teams are necessary, and we're learning how to do that. We would like, but we don't want community members to know that insurance still doesn't pay for a lot of that team to be in place, and so it's tough to keep the lights on and have enough people to help with everything that our patients need, especially in the city. So that's the crossroads primary care is at, and in some ways, it's a tremendous challenge, and we love it. We all know, Hopkins know, they're investing tremendously in primary care more than ever before, and it's really heartening to lifelong primary care clinicians like myself. It's where we need to go to improve our outcomes. It certainly is the way we need to go to save money. Saving money will help our health system globally, but I don't think any of us on the front lines think about money. We think about how to deliver better care. And hopefully if we deliver better care, we're delivering better outcomes and sustaining our system. So, pressures on clinicians are tremendous, and no one should feel bad. We all took it on and we all love it, but what we would like to do is be able to do more care of patients and do it more effectively. So I guess, we'd like our patients to know that we didn't keep you waiting for an hour because we were playing golf. I doubt any of us even know what golf clubs look like anymore. And that's okay. And so we'd like you to know that we wish we had margins in our schedule so we could deal with the unexpected, but we typically let patients know that we'll take the time when we need it, and that's, I think, very valuable to our patients. We'd like patients to know that sometimes what happened, the number of things we got asked to do before we came in to see you could have been well into the double digits, and so we have to take a deep breath and collect ourselves so we can give you the smile and attention you deserve. All of that. So this goes to all of our team members. We're asking now our front staff to take and do more tasks, and we're asking everybody along the way to do more with less, and I think that's good. We're learning how to do that, but that's behind a lot of the pressures. And first and foremost in all of our minds is how do we give the best possible care to our patients and our community.
So along those same lines, is this an opportunity now for us to begin to educate the community, the patients, differently about the Affordable Care Act and what it means to, to now be having the all-payer system and the accountable care organizations and all these things that are causing more buttons to be pushed? If they come with the knowledge, if we can educate them about their health insurance that oftentimes they're not fully aware of in the community, if we start taking little bits of time of giving them something or having small groups where they can get educated on really how to effectively and efficiently utilize their health care and their health insurance. Some people never had the card before, and so, this is their first time coming in. Is that something that you as a provider in the community at East Baltimore Medical Center has to take time to organize, or can someone at the front desk begin to organize that structure so that it keeps the patient-doctor relationship really tight, because I leave there feeling, you know what, Mike really cares about me. He's making certain that I get it.
Yeah, that's a great question. I think there's so many, and you listed a whole bunch of changes in medicine that we could, the Affordable Care Act, accountable care organizations, things that are changing the landscape of medicine, and hopefully in a good way. To me, the answer is that patients should come in and get all their needs met. I just couldn't tolerate a message of that we just can't do what we need, because that's less than what we should be giving. And so what we would like to learn, what you're suggesting is great at the community level. What can patients learn about navigating the healthcare system and insurance before they come into us, and then how can we have folks at our system ready to take over and help with those questions, such that once you get to see your provider, hopefully your questions can be medical and can be something that the provider can answer. Providers always want to help, and so when you ask a question, it kind of tears a little chunk out of them as they try to answer the question. And so they want to help you, but we want to make sure they can help you with what they're most expert in. And I can guarantee you we're not expert in insurance. So I think at the community level, I think the education should really be that the landscape is changing. It's getting much more complicated. Out-of-pocket costs are changing depending on what kind of insurance you have, and we're all trying to cope with that. And what is the clinics and the centers should hopefully have more resources available too. But that's a process in the making.
Thank you.
Great question. Well, Michelle, you've been. We were just speaking before. You come and see one of my colleagues, Janice Ryden at East Baltimore Medical Center. I don't think I've seen you in the hallway, but when you're there, I think I'm often there, and so now we'll be saying hi at a different level as well, which is wonderful. As a patient, and you're also a patient advocate on a community board for the research center, here at Hopkins. And I was going to ask, what have you experienced and learned? And what do you wish that the Hopkins professionals you've encountered would know from your perspective as a patient? What would you like us to know?
So much.
First, as like I said, Dr. Janice Ryden is my doctor, and I am here because of her. She thought I would be a good fit to sit here on the Community Advisory Board to eliminate cardiovascular diseases. I've learned quite a bit since I've been here with the board as well as East Baltimore. I have seen culture change. Now when I go into East Baltimore Medical Center, it's just not me I see in the mirror, but I see a lot of other folks. And I just need to say that we all come with our own diseases, our own prejudices, our own disabilities, and we have to be accepted one-on-one as individuals. I find East Baltimore, when I've gone to be clean, I have found that I've been there when there has been an emergency. I have been on time for my appointment, and my pressure, I'm sure, went up because I was there quite a while waiting to find out why I hadn't been waited on. I think that as changes come about, and we've heard some good ones today with the nutritionist and Dr. Reverend Hickman, we need something else there in place when there are crises and emergencies that happen, so that the patient of the doctor who is not available, who has that crisis, if we have fasted and we are diabetics and we have not had the opportunity to have anything to eat after 12 o'clock at night, I don't think it's fair if we sit there a couple of hours and no one says, do you need a pack of crackers? Can I offer you some fruit? I don't know what your situation may be. There's a vendor outside, may not be as healthy, a healthy choice that you want, but it's someone outside you can go, or give you the option of even changing your appointment. I think that's important because we get frustrated, and I'm sure it's not enough doctors, it's more patients than it is doctors, and they can't do but one thing at a time, even though sometimes I've been called the octopus because I multitask. But you find sometimes when you multitask, you do overlook. You can't help it because you are a human being. And that's what we need to remember. We are all human beings. We all want to be treated the same, whether it's an emergency, whether we're coming to have our blood pressure checks. We know with the unrest, the drugstores are not nowhere near where we live if we live in the cities. And if you don't have transportation, sometimes it can be difficult. I have found that if I use a pill box, I can keep up with my medications. I do have diabetes, cholesterol, high blood pressure. I do take an aspirin, but I've also lost weight. I've lost about 30 pounds within, say, the last 4 years. I lost my husband. However, I pushed back from the table. I have been a part of the 5+ beans and nuts. It's excellent. Some people don't like the DASH diet. Let me say this, as an African American, we eat DASH. I have a book, I have the cookbook, and it's not a lot of things you have to do to change. However, we have been taught one way in all of our nationalities, to learn to cook, to learn to exercise, to learn to pray. Prayer works. I know it works. I'm here today because of my community that has taken me under, including this panel here, because if it was not for the information that I have received during the course of my living, I saw a question on the board today that said, just to think if you're 65. Well, I was 65 last year, and I have learned to do quite a few different things. Learn to have a snack at night before I take my metformin and before I go to bed. I've learned to exercise. I've learned to walk. I had to learn to like me. It's not that I didn't like me, but what I found was that you gain weight, you raise your children, you go to school, you get your kids, it's a rip-rap run. So when we get to the clinics, we already know. We don't know what time they got there that morning or what time you'll be getting there in the morning or how late you stay in the evening. But I had read enough to know if you don't sleep for 36 hours, they think you're schizophrenic. So, you know, with this being said, I think that I have learned quite a lot from coming to East Baltimore. And I thank God for my doctor. And I thank God that I get the opportunity to come and speak to you, ladies and gentlemen, in the audience, to maybe learn from you, and maybe there's something I can say that will impact you, so that when your patients come in, you can say, let me breathe before I go in the door, but not wait. I saw something the other day that said they would only go in when the clock was on an even minute, and I'm like, that's so crazy. That is so crazy. Can you imagine the stress we would go through, and what we've been put through if we waited for the doctors to come in when they were on an even number? So, even, odd, indifference, we are all human beings. We need to help one another. We are a community. Hillary Clinton did not quote the phrase, it takes a village. We've known as African Americans, it has taken a village all of our lives. I am from West Baltimore. I come to East Baltimore to the doctors. My oldest child will be 40 in September, and that's where I started out with her. And so I've had a lot of experience. I've seen changes in doctors. I've seen changes in staff. I've seen the staff very professional. I like the staff at East Baltimore. They're very professional, and I know that things are done to motivate the staff as well, because the staff is only as good as the weakest link. And so if you empower your people that work with you, nobody's better than anybody. We're all individuals. We all know something, and we all are here because of what we've done with our lives at one point or the other. So, with that being said, with that being said, Paulton, you have a very unique perspective as both a patient and a researcher. What do you think your peers in each role do not know about the other that they should?
Thank you so much for that. I'm trying to follow on after your very, very wonderful words, because what you spoke about and what our colleagues here have spoken about already is a word that Reverend Hickman, you mentioned, and I want to make sure we elevate it, and that word was respect. And all the elements that you discussed and all the elements that we've discussed so far, they tie into that basic concept of respect. You know, when we think about linking this conversation up with the conversations about, you know, what some of the issues and events that have taken place in these communities across the nation, particularly over these past few months, I think what we're seeing here is we're seeing communities that are in some ways crying out and demonstrating how many of us feel as if we haven't been respected. We feel like we haven't been treated with the same level of regard or same level of consideration as other individuals. And so all of the elements that you spoke about, and all the elements that we've spoken about here already today, those all kind of tie into this concept of how do we demonstrate respect for the communities as a whole, but then also for me as an individual patient within my particular community. As an individual patient within my community, there is that communal side of me that researchers and clinicians have to be able to understand. But then also, I have my own individual context and experiences with my disease, which in my case is sickle cell disease. But you know, my own individual context with my disease, my own individual context in my life, where I am in my life, what are my goals, what are my dreams, what am I trying to pursue, and how then I think that researchers and clinicians both could take a little bit more time and try to better understand some of those individual experiences, some of those individual contexts. That's one thing that we know is very is useful in demonstrating respect to an individual and demonstrating respect to a community. And when you sufficiently demonstrate respect to individuals and community, that's where the trust comes in. Because as researchers and as healthcare providers, I think it's important to remember that trust needs to be earned. We have to demonstrate trustworthiness. Trustworthiness is something that in all of our discussions of trust and respect, we don't hear about trustworthiness as often as I think we should. healthcare providers. I think for many communities, healthcare providers and researchers are used to having a certain level of trust from communities built in. But for some individuals and for some communities, it takes a bit more work to demonstrate that you are worthy of the trust that you are expecting of us, and the trust that is so necessary to have successful clinical relationships and to have successful research relationships. So that's one thing that I think that I would wish that healthcare providers and researchers could just think about a bit more explicitly. How do we demonstrate that respect so that we can also, how do we show respect so we can demonstrate that we're worthy of the trust that we need from our patient populations and the communities in which we want to serve through research. From the patient perspective, this is something that I wish some of my fellow patients would understand a bit more, is just how much researchers and healthcare providers, many of you, really do care about us. You really do care about us and our concerns and our plight and our experiences. I think for some patient populations like mine with sickle cell disease, because we've had so many negative experiences in the past, it can be easy to paint all healthcare providers or all researchers with a broad brush that is more negative. And something that I've learned more as I started the professional side of my career and working day to day with researchers and working day to day with clinicians is just how much the majority of individuals in these fields really do care for us as patients, really do care for us as individuals. And I think if we as patients have just a better understanding of that, then I think that would also help with some of the communication issues, some of the communication troubles that we sometimes see between certain patient populations and certain healthcare providers. And then the last kind of point I want to make, I want to tie into this fascinating conversation that you all started a few minutes ago, and thinking about what are some things that you wish patient populations kind of knew more about, some of the challenges and limitations facing healthcare providers and researchers. I would just put in a plug, from my patient hat, my patient perspective, I will put in a plug for how do we develop some ways to educate us as patient populations about some of those real challenges, some of those real limitations that you are facing. Because I think many times, if we as patients have different expectations of what healthcare providers are capable of, or what research is capable of doing, if we had a better understanding of some of those limitations, then I think it would also help to emphasize so much more how much these healthcare providers, despite the challenges that you all are facing, how much you really do care for us, because you're going through all of these frustrating experiences, having to deal with all of these systematic problems and challenges that are affecting you and providing the kind of care that you really want to provide to us. So I think if patients had just a better understanding of some of those challenges, I think it would also serve to kind of help smooth out some of the relationships that we have between our healthcare providers and researchers. So I will just end on that note, and now I want to turn to my colleague, Brian. Brian, you are an educator, a father, and a husband here in this city. And you've also served as an advisory board member for a research center. And I'm just really curious to hear from your perspective, what role do you think that education can play in preparing high school students to be proactive patients, to be more involved in their healthcare and in talking to healthcare providers?
Great question. I don't know if I have an answer, but great question. I think, can everyone hear me? I don't know if I need the mic, but I need it. Okay. For me, just hearing the great information that's being shared here, I think one of the things that in our side conversations that we had prior to, and I asked you, when you talk about building relationships with your patients, the first thing is trying to build that level of trust. So before I go into the education piece, the simple question is, how many of you came in today and on your journey to work or in your journey in the building in the office, spoke to all your office mates? How do we open that line of communication just to say hello, to disarm some folks, to welcome people? So when we start talking about building relationships from that standpoint, that's one of the things I think that we need to look at. How do we just become more human in our relationship? As an educator, I guess the process that we use when we're talking about giving opportunities to students, giving them exposure, putting them in places that help to elevate. But more importantly, we know that the baby boomer generation now is there. So the example that I always give is, I had a student and we didn't understand why this student was always late or was absent. Well, after everybody looks at data, and we look at the days that the student missed, and it was always on these particular days. And from a standpoint of an educator, you don't want to be punitive, but there's some things that we have to get in place, because I can't educate you if you're not in the building. But what it came down to was that this high school student was more of a parent to mom, because mom had to go to dialysis at least twice a week, and she was the only one that could take mom to the dialysis, and so she would have to miss school along with get her younger siblings to school. And it's amazing that, wow, how do we share information, or why is this student afraid to share this information to get help? So my thing, when we talk about how do we impact our patients, how are we engaging, because we always talk about the youth are our future, but they're actually the present. So how are we engaging our youth? Are we using them when we start a research project to go out and do the legwork before you get the approval to talk to the community? Because we know our students need community service hours. This is a great way to, one, educate them on whatever's coming into the community, but let them lead the way of sharing that information in the community. What I've learned is, when I was an assistant principal and as a teacher, I didn't have to worry about parents liking me or disliking me. When their students love me, the parents end up loving me as well. So it was building those relationships with my children and with those students that helped to build those relationships with adults. So I asked, we know that Hopkins provides free tuition if you graduate with a certain GPA and you want to go to Hopkins undergrad. We know that Hopkins has a partnership with Dunbar. So those are some surface things, but again, when we sit here and we talk about what can we do to impact our students, we know that those same students are taking care of most of your patients. We know that they will need that information to translate, because they're going to have to go to the pharmacy to get that medicine. They're going to have to follow up to understand, this is what the diet is needed in order for mom to or dad to survive, so you don't have to go into the system. So I go back and more importantly, in engaging them, we have to build that line of trust. So in hopes of all of these things coming together, my point as an educator would be, how do we continuously engage and impact our young people where they're becoming advocates for doctors, they're becoming advocates for the medical system, they're becoming empowered with the information to take back home. More importantly, at some point, they're going to be patients. Many of us, including myself, a lot of times we're afraid to go to the doctors because we don't want to hear the bad news. So how do we explain to them in a proactive manner so that they can share that information? So building programs that foster that professional relationship, be it an internship, be it that they do on community service, or you're coming in to speak to students, but really engaging them from that point of trust. So in order to get that piece started, the one thing that I will ask that you do is learn to be more honest in your process. I think this will go to a conversation that we just had earlier, and although it may be off tangent, it's very relevant to building that trust and moving forward to building that patient confidence. We talked about, I live in Mount Washington, so Park Heights is a stone throw away, and the issue is I have a Jewish neighbor who talks about, we don't feel comfortable sometimes when we have to go to Park Heights area to go worship and things like that. And it was simple. We had this conversation. I said, when you're walking, how often do you say hello to the people that you pass? Because that in itself sometimes disarms whatever you think is going to happen or not going to happen. But more importantly, it starts a dialogue. Because the more that we feel that you're sincere or I'm sincere, hello becomes more than, hey, how are you doing? And it engages us to go to the next step to find out. And what I explained as a teacher, when we think of Columbine and all these school shootings, as educators, if we start talking to our students more, if we're at the door and we're greeting them hello, we give that student, the opportunity to share something that was horrific for them that they didn't share. Because many times, that's what happened. It builds up to that process. So what we may need to do is understand that we're not always going to get that A student, because our A students are going to go out and do the work. So as an educator, I always tell teachers, when you grow as an educator, remember, you're going to know your A students and you're going to know your trouble students. But it's that C student who just happens to come and do exactly what they need to do that we need to get to know. So as practitioners, those patients that love you, you know you're going to know. Those patients who rate you low, you're going to know because you're going to have to go out to get that high rating. But what about just the average patient and building that relationship? So let's try to find a way to use our youth to do that. That way that they become the mouthpiece for you about whatever it is that we're trying to do and build. And it becomes a real community process. I'm supposed to give it back to Lisa.
So anyway, so I don't have a whole lot to add because I think this group has actually just really embodied a lot of the things that I've learned throughout my career as a clinician and as a researcher. So they've put a face on a lot of the numbers and the data that I've collected with my colleagues, you know. So one of the things I learned as a resident was that people in Baltimore faced similar challenges to the patients, to the people that I saw in Africa when I was growing up. So like growing up in Baltimore City, a lot of times people had struggles with housing, they had unemployment, they were hungry, they were poor. There were similar issues, and so that's one of the things I learned. That's one of the reasons I got interested in studying health inequities and how the healthcare system and how doctors could actually work in that area. The studies that I did showed that patients really value trust in doctors, and that was like very high. And they showed that when people came from different backgrounds, they communicated differently. In fact, they didn't communicate as well, and patients ended up leaving feeling like they weren't involved in decisions about their treatment. So none of these things are surprising because I had seen them in practice and you've heard the stories, but actually these are data collected on like thousands of people that pour out this information. So we use that information to develop interventions, and so we know now that there are things we can do, you know, to make that better. We can train our medical students, we can train our clinicians to talk in a way that is more respectful with patients, to allow people to ask their questions and to express their concerns. You know, we can show them, we can actually empower patients by using coaches like community health workers and, you know, other people like in the clinic, on the team to help doctors, you know, deliver a more kind of holistic approach to care. So a lot of that is what I've learned in my research and, you know, in my role as a clinician and an educator here, but you've heard it from people who are like on the front line. So I don't have much more to add, but I think what we'd like to do is to hear from you now. Now that you've heard from us, you've seen a lot of the data on the screen and the statistics and the quotes from various people from different walks of life related to communication and relationships and how they impact social inequities. Now we want to hear from you. What would you like to know from us that we haven't addressed so far? Are there perspectives that you have that you'd like to share with us? So, and Reverend Hickman wants to add one more thing, so I'm definitely going to let her do that. And before I let her do that, though, just in case everyone sort of leaves, I want to make sure I thank my assistant, Joy Mays, my project manager, Jennifer Halbert, to thank Tamela Knox, and to thank the entire planning committee for their help in putting this together. So, Reverend Hickman?
That one more thing that I really wanted to say about research as well as clinical care is incentives. That's the bad word, because clinicians as well as researchers don't want to hear the word researchers because they say funding is limited. But when we talk about the uprising and all of the community engagement and the involvement of community looks at it that you're being paid and they're struggling, and that they're coming and they're sitting in the clinic for hours on end, and sometimes no one offers them anything, or you're telling them to go out to the vending machine, get something because it's going to be a while, but you don't know that their gas and electric is about to be turned off, and they have their last $1.50 in hand. And so I think that that's a valid conversation that does need to be had and does need to be reviewed in the process. Incentives not to go out, not to encourage someone to just be there but for people that want to be involved in the research, they are due to be paid. You have no idea as to how the community members struggle daily to have a place to live, to keep their lights on, to have a decent meal beyond a chicken box and a Pepsi and a bag of potato chips. We have to do something different in the structure of the guidelines that help people to understand. Incentives can be based on things like making certain that they have a soap powder packet ready, a laundry packet ready to help them get to the laundromat, with a roll of quarters so that they can do their laundry. It can be to the food market so that they can actually go and pick up a healthy bag of groceries from the market that is closest to them. It could be as lucrative as making certain that they have some free dental care for 3 visits, and which dental care is something that we have not talked about a lot in our community, but it needs to be talked about because it's one of the leading markers that leads to bad health, to cardiovascular disease and the like. In our community, you go and you smile at Sammy Joe and he has a gateway in his mouth, but that's not funny. It's like we need to really take these things into consideration when we're developing our programs.
Thank you. Okay, so can we pass the mic? Are there any questions for the panel or any perspectives?
Hi, I'm Stephen Ragsdale. Thanks for having me and inviting me. I have one question. I think that you guys talked about it kind of tangentially, but it's directly related to economics, the economics of research. And I'm always reminded, whether I'm in the boardroom or the barbershop, that this has economic ties. Harriet Washington published a book a few years back, Medical Apartheid, that the thesis was loosely that medical research, minority communities and vulnerable populations are generally used to improve the health status of other communities. She talked about that again in Deadly Monopolies and the work that's being done by the pharmaceutical industries in Africa. That question actually comes up a lot when you are in the barbershop, if you will. Have you ever faced that question? And if so, like, how do you take research subjects who are at that place and say to them that downstream that there will be an economic benefit to not only you but your community? Thank you.
So, easy question, right? Well, I will take a stab, and then I don't know if anyone else wants to jump in. I mean, I would say yes. That issue has definitely come up. I find that using the same principles that we've been talking about here related to building trust come into play. I think we have to recognize that even though we might have something that we're trying to accomplish in terms of completing a study, that it's not all about doing that at that moment in time. It's about building that relationship and about establishing that trust. So you may have to just sort of throw out the window the fact that you have this agenda that you want to recruit this patient or you want this person to do this, that, or the other. And just stop in the moment and say, you know what, tell me about what's going on with you. Like, where did you hear about this? Or how is it that you feel, what made you come to feel this way? Where did you hear that? And be really, truly curious and concerned about that so that you can take that information and learn and realize that you may not actually end up succeeding with that particular individual, but what you learn can be used in the future, And it's about that longevity, that knowing that person may not join that study, but knowing that you're authentic and that you truly care and that you heard their perspective and that you're still going to be there like in 2 years, and that the study you did like, across the road like last year, that you actually came back and shared the results, and that you're working with the decision makers to try to change things so that the program can be sustained. They're watching and looking at all of that, and it doesn't happen overnight. I've been doing this for 20 years, and some of the things that I was working on 20 years ago are like now coming to fruition. So you have to be in it for the long haul, and I think, that's what this is all about, and I think that's why this series is called Journeys. It's not about something that we just do and we're done and we figured it all out. We're going to be working on this for a while, but just realizing that it's a process, and maybe one day we'll get there, but it's maybe not so important exactly where we get as what we do along the way.
Can I expound on it? Just, I think one of the things that you talked about with that economic disparity, the process for me again is when we start a research process, how can we tie in some other benefits that may not be necessarily related to the research, but necessary for the community? And that might be something that, as we move forward with research, especially medical research, that you start looking at. And I think you said it, and it's just giving those extras to the community. But I think more importantly, you really have to be honest with where you are. There's some things that, you know, I would say that as a researcher, maybe I don't have all the answers of where this is going to go, but I definitely need you to get something, you know, to be able to have a baseline of data to move forward to better help people. So I think that being honest and open, but also maybe trying to find a way to tie in some incentives like you spoke before of how it can benefit the community so that they can see that process.
Yeah, I won't belabor the point because both my colleagues here just said kind of thoughts I wanted to share. Exactly, I think part of it is how do we better educate communities about just the research process and how through the research process we do have to take that long view. To what extent can we build in some of those ancillary benefits that you spoke about? Because what Harriet Harrington and those researchers in those books really talk about is the issue of exploitation. So we want to then help our communities, help our research participants, help our patients, you know, understand, you know, that long view of the research process and how, if you can show examples of how, you know, either going back with your own data or show examples how others of your research or research like it have led to some improvements, maybe in healthcare, things such as that, so that then we can begin to see, okay, there's kind of this history, there's this trajectory of research that's happened, benefits that have come back to community, and how it's this kind of cyclical process, but it's this long view process. We can help people better understand that. I think it will help minimize some of those concerns. May not take them all away, but help minimize some of those concerns.
All great answers.
Hi, I'm Carmen Alvarez. I'm a nurse. And so I would like to hear from our community members how you would like to see nurses better serve your communities.
I think that nurses better serving the community look like coming to the community-based organizations and doing monthly educational series. I think that going to the churches and showing up, you know, there as well, because that's a massive gathering place for our community members to make certain that they're getting the education to set up doing the diabetes screens and doing hypertension, you know, the high blood pressure screens and the like, showing them how to utilize their apparatuses, showing them and working with dietitians on how to have healthy meals when we have after church service. Not all of the fried chicken and the gravy and all of those luxurious items that we love to eat after service, instead of, you know, just showing up when we see the nurses there in the hospitals or there in the clinics. But we really need for the nurses to embrace the community, maybe even on foot traffic, just checking on neighbors and helping, you know, to be more efficient and helping them to better understand how to navigate the medical system a little bit differently. I think that nurses have a heart that's different from any other group of people that care for life itself, and they need to feel that human touch. Nursing has really taken a massive turn from the day that I started out as a nurse, as a licensed practical nurse. They no longer, a lot of nurses nowadays, if you call for a bedpan, they don't put you on the bedpan, they have a technician to come in. I think that we need to take all of the classism out of these types of positions that have come about. Instead, we're all care deliverers, and so let's be compassionate and deliver the care at the time that is being done, instead of seeing it as a moment by which I get to show you my superiority. I have been to school, and so therefore that's a job that's beneath me. I pass it off to this person, and this person might have 15 or 20 persons that they're taking care of that night or that morning, and they can't get to that patient, and that patient has already had an accident and made to feel like less than if someone had just helped them at that moment. So those are all the areas that I think if we could just be more embracing as nurses in the community setting, as well as in the church setting, as well as in the institutions, you know, the clinic and the inpatient settings, it would really be a great help.
I can add, you know, I'll talk.
So if no one else has a question,
I think there was a question from the audience.
Michelle has one.
Michelle?
Yeah, I don't need a mic. This is actually a continuous thread in the conversation, but I wanted to ask Dr. Albert, I guess specifically, if you could, and this is from my own perspective as a patient and exposure experience here at Hopkins to research, sort of seeing both sides. I've had many experiences going into a new practitioner, and I'm wondering in terms of improving cultural relationships, you know, cross-cultural, you know, relationships between patient and physician, particularly when the physician is white and the patient is African American. Are there any specific kinds of ideas you have, any measures that could help us move towards improving that? And I just want to mention that Carlton, I know that Carlton and I have known each other from bioethics and everything, but Carlton has been part of a lot of research and has helped produce a video. I think it's entitled "They Don't Believe Me." Is that one? And I think it touches on his experience as a sickle cell patient and the perception of, you know, the perception that practitioners have when he comes for treatment, for crises, you know, how they respond to him versus someone else who's not African American, who's white, coming in. So I wondered, like, what thoughts you might have about improving that.
Yeah, that's a challenge. You know, when you think about clinicians in general, regardless of their race, ethnicity, or background, you know, we're all trained to take care of patients equally, but yet we also have hard medical data that suggests that we should treat populations differently. That's good medicine, right? We should recognize different risk factors described in different populations. But that doesn't begin to address cultural competency, which I think is what you're getting at. And that's that's become more current, I think, in medical education, right? We need to get people early on and teach them this, you know, regardless of the population. You know, in Baltimore City, broad brushstrokes, you need cultural competency for the African American community, the white community, Latino community. You know, that's going to make the large majority of who we see, for example, at East Baltimore Medical Center. And you know, it's not, physicians have to, caregivers, care teams have to be culturally competent. The care has to be that way. At the very minimum, when there's gaps in knowledge there, we expect and we should have care teams, exhibiting openness, open-mindedness, and inclusion as principles when they're communicating with people. Because ultimately, the first principle is for any clinician to treat a person as a person, right? And be open to what they're telling us. Now, the more we can learn about cultural backgrounds and differences, the more effectively we can give care. So the answer is, I think, education. I think open-mindedness. I think it's a change and that's certainly it's beginnings in medical education. But we all know as physicians we didn't learn everything we know in medical school. We learned a lot afterwards, thank goodness. Otherwise, we could think of all the things we'd still be doing. So in any case, I'm not sure I'm really answering your question, but clearly it's an effort that we need to do better at. And I'd be the first to say, one of the biggest challenges I think is that we have a lot of brilliant physicians and clinicians in our country, in Hopkins and in Baltimore, and not all of them are natural communicators, but they're great at taking care of patients. And so that's a challenge, right? What maybe selects for great doctors who take great tests doesn't necessarily make them natural at communicating and bonding with patients. And so, we want to select the smartest people to be clinicians or the most compassionate. We need to select for a lot of different qualities, which don't always come innately to everybody. We know that because humans are humans. And so trying to teach clinicians to have great communication skills, I think, is the first start, and layering into that cultural competency.
And I'll add to that, my cousin Michelle, a lot of the work that I've done in training clinicians does focus on trying to foster attitudes that are more open to, different cultural differences, and actually increasing awareness among clinicians that we actually have biases, that we're not immune from that, like the rest of society has them, we have them too. So that's part of the cultural competency training, and it's been shown that increasing awareness of bias and actually helping people develop ways to cope with it and to manage their emotional responses when they're in a situation where they're different from someone else and there's some anxiety about how they interact with that. Giving people good communication skills, giving them effective ways of handling their emotions, dealing with stress reduction, because we know a lot of this stuff gets worse when people are under stress. Mindfulness training, there are lots of different things that are being tried now in medical education. And then the whole selection process is now being changed, where we're not only looking for clinicians who do well on standardized tests, but we're actually looking for people that demonstrate more humanistic qualities and more of an interest in sort of the more interpersonal side of medicine as well as the technical side. So we're making progress. But I want to make sure that we are being mindful of people's time. I've seen people kind of filtering out. Do we still have time, or should we try to wrap this up?
Can I just say I want to applaud you, Dr. Cooper, because I've worked to support the, just a couple of weeks ago as a community relations coordinator with Dr. Cooper, but specific to this conversation, I've also worked with you as a member of the Horizontal Strands Committee, which is a committee that's part of the curriculum report for the School of Medicine. And Dr. Cooper represented the study of health disparities as part of the curriculum, along with other types of things that are important in the future training, like cultural competency, understanding pain, understanding better communication. So you've done a lot in that area, so appreciate your efforts.
If I could have your ears for 2 minutes, because now is when the conversation, seemingly for me, is really starting to heat up a little bit. Because I think some of what we really need to really discuss is the humanistic components of medicine and community. And it's not an either or, it's a both and. And I think that in the uprising, what it showed us is how human we each are and how we need each other. Emmanuel A&B situation of 9 people losing their lives showed us that we don't need to take to the streets to demonstrate, that we need to have a heart of forgiving, and we need to understand how to respect and talk with each other, irrespective of what our degrees are and what we believe is our class standing. And that's some of what has taken place in the journey of medicine and community that has caused great divides and great disparities, and to the extent where community has a breakdown that they don't trust because there is information that is collected, demographics get collected. What are those demographics used for? They are usually a dividing line. They say African Americans have more of this, have more of this, Hispanics do less of this, and these types of things. And these are things that are various. They throw up walls and they make people pensive in community and participating in the research and showing up at certain clinics. And also providers talk at us instead of talking to us and being with us. And I think it's important that we learn how to talk with and not at, how to become familiar. I won't ever forget going to my neurologist, and he was steadily putting in his data because he had to, Mike, because these are things that he has to do. And so he's talking, but he's not looking at me and he's not engaging. He's asking just enough questions to get a little bit of information. And I said, maybe I need to find another neurologist, because I'm quite certain if you were sitting where I'm sitting at right now, you would not want to be treated the way I feel right now. Would you want your wife to feel this way? And he stopped right away. He said, am I doing something wrong? I said, yes, you're doing something wrong. Let's have a relationship here. I want you to understand that I know how I feel, and I want you to care about how I feel. From that moment to this moment, he is the best neurologist ever. I mean, I got to learn in that moment about him because he shared with me, you know, my mom has cancer and that, you know, I've been taking care of her. And we had the most wonderful time in a 20-minute period. And he has helped me so immensely that I know that I could get online and I can send an email about issues that I'm having now, instead of waiting 3 months for my next appointment. I have providers that are awesome because we can communicate. And I think that that is a part that we need to sensitize the providers, our students that are coming out of med school now, about just be yourself. Come, you know, if you come in the room, the community respects and loves when you just relax and be yourself. And so that's what I really want to say about, even in the research, if we can just be ourselves, be honest, we don't really know what's going to come of the data, but on the outset, if you can identify some people that really want to come alongside and help us figure out the sustainability portion while this group is working on this, and we work with the clinical component to make certain that no one gets lost in the sauce, you'd be surprised at the change that would occur in community. You would be surprised in how people would change their attitudes about what's taking place. On the community side, we need to do more building, more education with our community members so that consumer protectionism is always in place. We need to have our own consumer IRB taking place simultaneously with the other IRBs to make certain that we're all going to be compensated in this process.
So on that note, I don't know if I can say it any better. I just want to thank all of you for being here and for engaging with us. Remember to be kind, be caring, be respectful, and let's continue this conversation. So thank you.